Welcome everybody to this EuroELSO webinar. My name is Peter Roeleveld. I'm a pediatric intensivist from Leiden in the Netherlands, and I'm also a member of the EuroELSO steering committee. And I have the honor to host this webinar. We've got some excellent speakers from all around the globe today. We've got Tim Jones to start off with from Cambridge. Who will talk to us, Birmingham, sorry Tim, who will talk to us about weaning and the surgical perspective. The entire program today is going to be about weaning post-cardiotomy ECMO. I want to ask all the listeners to post questions in the question box, and I can then relay the questions. I will amalgamate them, and then I will relay the questions at the end of the three talks, and we can have a discussion with our expert panel. So, without further ado, I would like to ask Dr. Jones to start off and give us his perspective on weaning from post-cardiotomy ECMO. Thank you all.
Okay, well, thank you very much, Peter, and thank you for the kind invitation. It's great to be part of this. So, strategies for successful weaning from post-cardiotomy ECMO in children, or surgeon's perspective. I'm sure there's going to be a bit of overlap between our talks today, and make no apologies for that, but really it's just coming at it from different angles. And what I'm going to cover is, we're going to go through a bit of the way of the aims of VA support, discuss the principles of myocardial recovery, gain some overviews of the signs of myocardial recovery, outline the requirements for successful weaning, and understand the cardiac physiology so we can optimize the physiology during that weaning process. And then from the surgical perspective, talk a little bit about neck vessel reconstruction post-decannulation if you've done peripheral cannulation. Okay, now look, I'm going to start off with a very general slide. What are the aims of ECMO? You all know this. The aim is to preserve end organ function, to allow myocardial recovery, and either enable surgical correction of an anatomical problem or a bridge to a longer term destination. And if we're talking about successful weaning, it's obvious that the success of your weaning starts right back before the run begins with successful patient selection. You've got to believe that the patient you're putting on has a reversible cause of their cardiac failure, and they're going to wean successfully. Now, we're going to preserve end organ functions, we've got to flow and oxygenation, you know all that. But let's talk about allow myocardial recovery, because this really is one of the things that underpins successful weaning. And from the surgical point of view, I sort of take these thoughts from how we protect and recover the heart in the operating room. I'm going to talk now particularly about pediatric hearts, obviously, and probably a lot of focus on the neonatal myocardium. So if we're going to allow myocardial recovery for a successful weaning, we've got to offload the heart. We've got to avoid and treat myocardial distension, maximize myocardial oxygen delivery, and minimize oxygen and energy usage. Now, how do we do that? Well, to offload the heart, we've got to treat hypertension. So during our run, if we're going to wean the patient successfully, we've got to have a protocol where we really don't let particularly neonatal heart beat against high afterload. So aggressively treat hypertension with a pure dilator, not an inodilator, not a phosphodiesterase inhibitor, because that will use up myocardial oxygen and energy. Myocardial distension, really vital, and I'll come on to this. We've got to look for it, and we've got to make sure the hearts are adequately decompressed. Maximize myocardial oxygen delivery, again, adequate decompression. We can consider increasing the ventilation, that the coronary arteries, the first blood they see is that ejected from the heart, so maybe there's some advantage to using the lungs. But I think in the early stage of a cardiac run, I wouldn't really do that. I'd just rest the lungs, because often there's a bit of lung damage going on as well. Minimize myocardial oxygen energy usage. As a surgeon, the most frustrating thing is seeing a post-cardiotomy patient on ECMO to come in the morning. There's been low blood pressure, so someone started Ionotropes overnight. That just knocks us back on our myocardial recovery because of the oxygen energy use. So do not use Ionotropes other than just have some rescue adrenaline available. Now, why do we talk about adequate decompression? There's no doubt in the adult ECMO population, the adult heart has more compliance. It's able to tolerate an increase in end diastolic volume better than the pediatric heart is, and particularly the neonatal heart. Now let's just look at some basic physiology why I say that. We know that coronary perfusion, which is really the vehicle to recovery, you've got to get oxygen and nutrients back into those coronaries to recover the myocardium. Coronary perfusion is driven by the aortic diastolic pressure, minus the end diastolic pressure, and particularly be the left ventricular, right ventricular end diastolic pressure. Now, we're on ECMO, we don't have systolic diastolic pressure with a mean pressure. So the aortic mean pressure, you can see running here, and the end diastolic pressure here. So we need a gradient between those two. Now, if we run, say, a neonatal ECMO, and we're running with a mean pressure of 40 millimeters of mercury, might drop maybe to 35 millimeters of mercury. If we find that the end diastolic pressure is increasing because the heart's becoming distended, and as the heart becomes distended, end diastolic pressure will come up. It's clear that that perfusion pressure, the difference between the 35 to 40 minus maybe comes up to 15 to 20 of your end diastolic pressure with a distended heart, that you really have a big reduction in coronary artery perfusion. And that is particularly so in the child, and even more so in the neonate. And this really is because of the Laplace law, where we know the wall tension is equal to transmural pressure times the radiance and the wall thickness. But let's rearrange that equation now, and let's look at that transmural pressure, the pressure exerted here, back from a small, let's say this is a left ventricle, and we can see there's an inverse relationship between radius and that wall pressure. And so the small neonate with a small radius to that ventricle can rapidly increase that pressure with a small gain in end diastolic volume. So we've got to make sure these hearts are decompressed so we do not put up the end diastolic pressure, which will reduce our coronary perfusion. And this really is the key. The heart will not recover. You will not be successful unless it is decompressed. And this is particularly so for the neonates. Now, how do we achieve this? Well, we've got to look for it, first of all. We've got to do regular echocardiogram. There's no point just doing an echocardiogram at the beginning of your run. I really would advocate daily echocardiograms, and any concern about distension, repeat even more frequently than that. If you've got an ASD or VSD, well, that's excellent. Hopefully with a right atrial cannula in situation here, we'll be draining the left side of the heart through the ASD or VSD. But if not, you're going to have to think about doing something. And in the operating room as a surgeon, if I'm going to go on to ECMO, I will actually make sure that I'll leave, even have to go back onto bypass to create an ASD if I know I'm going to be going on, or fear I'm going to be going on to ECMO post-operatively, as a sort of precautionary thing to make sure I can decompress the left atrial side. If I can't, and I'm putting the patient on post-operatively in the ICU, and I don't have the luxury now to open the heart there, then I'll put a left atrial vent in situ, either venting via the right upper pulmonary vein or the left atrial appendage, and teeing that vent back into my venous drainage line. If that's not possible, so we haven't got an open chest, we've got peripheral cannulation, unlike very rare sort of post-cardiotomy, you can normally get into the chest. But obviously, if you are in that situation, then a balloon septostomy, and this is something we've done a number of times in the cath lab whilst on ECMO, it is again incredibly worthwhile and will help decompress that left side. Hopefully post-cardiotomy, we've got some pacing wires in situ. And again, just think about a slightly higher heart rate with some AV synchrony. So DDD pacing, 130, 140 for the neonate can often also help that heart empty. And of course, we have to be careful of the situation left ventricular stun, where we don't know why, but for some reason, the first sort of 48, 72 hours of a VA run, we can see the heart just suddenly not contracting and distending. And I would really call that an ECMO emergency, because you've got to decompress that heart. Otherwise, you'll cause irreversible myofibril disruption and obviously ischemia. And the same thing if you're in a cannulation situation with the aortic valve been held open or forced open because of a misdirected cannula, that needs to be dealt with as an emergency. Now, what else about successful weaning? And I can say this as a surgeon. I know as a surgeon, we like to think we never get it wrong, but we do. And actually, if you've gone on to ECMO post-surgical intervention, one of your first assumptions has to be, have I not got the repair correct? Or you've got to be able to say in very nice terms to your surgeon, do you think maybe there might be something perhaps wrong with the surgical reconstruction? Or shall we just be for sure, to make sure you've got it right, as always, go and investigate this patient? And obviously early investigation, we used to use cardiac catheterization, we are using more CT scan now. And we can see the data is quite stark, isn't it? Echo detects only 19 to 40% of residual problems. And when you do pick up a residual problem, treatment can be instituted, and actually the catheters and the CT scans often pick up unexpected findings. And when you treat the unexpected finding, you can have recovery. And this is vital, because obviously in the situation of, say, an arterial switch patient, if you haven't got the coronary transfer correct, or say a post-Norwood, you haven't got the Damus correct, it does not matter whether you're delivering the best ECMO in the world. You will not successfully wean that patient until you correct the underlying surgical problem. So yes, early investigation. There's no point sitting flogging us a patient who's still got a residual anatomical problem, particularly if it's to do with myocardial perfusion. Now, how do we know you get recovery? It's one of these bizarre things, I think, that often nothing happens for the first 3 days and you're beginning to lose hope. This is post-cardiac surgery now I'm talking. And usually by about the 3rd day, you begin to see some recovery in myocardial function. Not enough maybe to come off, and I doubt it by 3 days to come off, but you should see some. If you see no myocardial recovery by 3 days, and certainly no sign of myocardial recovery by 5 days post-operatively, that's a very bleak sign. And that really, if you haven't investigated, you've got to investigate the patient. Hopefully you've done so beforehand, but if you have investigated, there's nothing correctable and there's no recovery in the myocardium by 5 days, you've really got to be having some very serious talks with the family. We've mentioned about early cardiac catheterization, CT scan. How do you know you got recovery? Well, obviously you'll see it on your echocardiogram, but remember, you're not preloaded. The echocardiogram without the preload, if you're on full flow ECMO, can sometimes underestimate the recovery in ventricular function. You'll begin to see an arterial waveform return. You'll go from that flat line to a nice spiked waveform, but be careful, because the modern generation monitors often are on an auto gain setting. And I think we've all been fooled where we've come in the morning to the ICU and you look up immediately at the monitors, you walk over and you see a beautiful pulsatile waveform, only to see the numbers saying that you've got 43/40 pressure and only 3 millimeters of pulse pressure give you that lovely waveforms. But you should see a decent pulse pressure here between systolic and diastolic pressure. You'll begin to see a decreasing PaO2 as the heart recovers. Patient PaO2 this is, and I'll go on to explain in the next slide why that. And obviously the filling pressures of the heart will begin to come down. So all good signs you're going to recover. Now, why do I say you're going to see decreasing PaO2? And this is taken from one of our actual ECMO runs that we've done. And what I'll just familiarize myself here, here's some blood gases. You can see we're not automated. We're a good old-fashioned English approach to life. And you can see here we've got 3 gases down here. You can see the bottom one, the black one, and let's just focus on the PaO2, and these are in kilopascals. And I put the conversion there for those of you who are working in millimeters of mercury or centimeters of mercury. So we've got, in our venous line, we've got 5.3 kilopascals, okay? Post-oxygenator is the red number here. We've got a massive step up. We're well oxygenated. And this number is taken from the patient's arterial line in a limb. And we can see there's a big step down between 60 to 20. Now, this means there's got to be a lot of deoxygenated blood coming from somewhere. And obviously this schematic shows what's going on here. The heart is recovering. It's ejecting well and pushing all this deoxygenated blood out. So this is a good sign of recovery. When we go on a run, first of all, we often see that 60 post-oxygenator, and maybe the other number will be 58 or so, showing minimal ejection. But when we see this sort of gradient, that heart's recovering well. If we see 60 post-oxygenator and 60 in the patient, well, that's, you know, sign for an emergent echo needed, because then we've probably got a situation of myocardial stun and there's no deoxygenated blood going into that patient's circulation, so the heart's not ejecting anything, would be our assumption. So really useful to do those triple gases around the time of weaning, and also we tend to do them twice a day just to make sure things are okay. Very briefly now, weaning, when, where and how, just to run through some sort of general comments. We've spoken about the timing of weaning. And then what I want to do really is just to think about weaning versus trialing. And these are 2 expressions we often use. Weaning, we use as a, we're going to reduce the amount of ECMO flow and see whether the heart can take over the circulation. And if we're looking in a good position, then we'll clamp off and we'll trial the patient off. Now, weaning, what we often do is maybe sort of day 3 or 5, if there's some recovery, it's quite nice to have a look to see what the heart can do. And if things are looking good, we'll go on to a trial. But be careful about weaning repeatedly. because this actually is a physiological challenge for the patient again. And there's no doubt if you've had a failed weaning or a failed trial, you normally need at least 48 hours to recover from that before you can attempt anything else again. Elective versus emergent, well, clearly we'd like to wean the patients electively. However, if there's a problem with your circuit, never disregard the possibility that actually the patient might be ready to come off, and whilst it's not an emergency weaning, actually if you're almost there, and a couple of patients we've taken off in the early hours of the morning when we found that the circuits either begin clotted or something like that, and actually we've done a sort of fairly rapid wean and then trial and got the patient off. And also if you're on for cardiac failure, everyone forgets about the lungs, the lung function, and is the ET tube right before you come off. So you can wean in the ICU or the OR, it doesn't matter as long as your surgical team are happy with where you're at. And obviously, you can wean as part of an investigation, go to the hybrid lab where you can investigate the patient, operate on them to deal with the residual problem, and often they'll come off as part of that. The planning stage, clearly you've got to think about what you're going to do with your heparin. We split half and half on the patient and half on the circuit. We do use a bridge to preserve the circuit when we come off. And think about vascular access you're going to need. Once you take your ECMO circuit away, what vascular access are you going to need? If you're using renal replacement therapy during the ECMO run on the circuit, you're going to need to think about how you're going to manage that post-operatively. And obviously you've got the right personnel equipment around, and you've got to think of an inotropic and ventilation strategy. You've got to know what's going to happen if you're not going to successfully wean that patient before you attempt the wean. Are you going to have a second? Well, first of all, are you going to go back on and then wait and recover further? If you're going to come off and decannulate, are you going to have a second run? If you are, what's your recannulation options? And discuss this with the parents before you get into the situation. Have a group discussion and then decide what the future is. And finally, really, how are we going to do it? And this really is sort of basic cardiac physiology, isn't it? And this is really what I think of every day when I'm trying to take a child off cardiopulmonary bypass and I apply this to ECMO. We've got to make sure we've optimized the heart rate and the heart rhythm. It's the first thing. You have to preload the circulation. Afterload, I only use as a second resort, particularly if I'm trying to bring a neonate off an ECMO circuit. In contractility, obviously, we're going to be using our Ionotropes. Never forget referring to these basic equations, because these are the two equations that apply everywhere in the world. Blood pressure is cardiac output times SVR. So if you want more blood pressure, you can only do it by one of two things: increasing cardiac output or increasing SVR. Avoid increasing SVR if you're trying to recover the patient. Increase the cardiac output, and you can only do that by increasing one of two things. Make sure you've optimized the heart rate and make sure you've optimized the stroke volume. And we come back to our Starling curve, don't we? In the bypass room, we've got the luxury of adding and taking out fluid to see if we can move someone up and down the Starling curve. The problem in ECMO is adding fluid to the circuit and they don't come off, means you've then got to try and get the fluid out of the patient. So you might be better just a little bit of fluid, then a little bit of inotropy to see if you can come out. And we always wean with an epicardial echo so you can make sure you know what's going on. And finally, neck decannulation. Yes, we all want to try and reconstruct the vessels. It's not always possible. Is it essential? Well, not really. The arguments for and against don't sort of swing in particularly one direction. They don't say that there's going to be more brain damage if you do one or the other. They don't say one's going to be better in the long term than the other. I think the approach is, if you can reconstruct the neck vessels, do. If you can't reconstruct the neck vessels, then you can tie them off. And if you are reconstructing them, yes, there are some good patency rates. People are getting in excess of 90% patency. And what you need to do is to inform the family whether they've got a patent, particularly carotid artery or not, post-operatively. And we know that basically, if the carotid artery is patent at the time of the patient leaving, it is likely to remain patent. It may well become slightly aneurysmal, or it may well narrow down, but certainly all patients should have a Doppler of the neck vessels if you've gone on with peripheral cannulation for whatever reason and you've reconstructed the vessels. And then really there should be some surveillance over time to make sure that those vessels do remain patent. My final point is, once you come off ECMO, remember now you've got a critically ill ICU patient. And I think we all often drop the ball with that. We've indulged everything in this ECMO run. We've come off and now we've got a very sick ICU patient. So successful weaning should be followed by intense, successful ICU to get the patient out of the hospital. So in summary, we've gone through these things. We've discussed the aims, our myocardial recovery strategy, how we wean, when we wean, and also we've spoken about a little bit of the physiology around that. So I'm happy to take any questions, which I think we're going to take at the end of the next couple of talks. Thank you.
Fantastic, Tim. Thank you very much for this overview and your thoughts. And yes, I am looking forward to the questions and the panel discussion, but like you said, we will do this at the end. So now we will proceed with Dr. Roberto Chiletti, who is a pediatric intensivist all the way from Melbourne, Australia. It's 2 o'clock in the morning, so you're my hero. Thank you so much for being here. And to share your thoughts and your insights, what you think strategies could be for successful weaning. Roberto, take it away. Thank you very much.
Thank you, Peter. Thank you for the invitation, and thank you for keeping me up so late at night. So I'll try not to be too delirious. I have no disclosures. I'm really pleased that I actually thought I'm going to focus a lot more about the practicalities and the nitty-gritty about the weaning of mechanical support. And Tim probably has focused a lot on the first part, which I actually was not planning to talk too much, was about the period between the patient going on ECMO and starting to think about the assessment of the readiness to come off and the weaning process. And as we all know, the whole first part before trying to come off ECMO, a lot of the problems are related to the fact that the patient could have had an ECPR rather than electric cannulation. Depends on the underlying condition, on the complication of ECMO and the complication of the cannulation, and they will influence not only if the patient is going to come off, but also the timing of the decannulation. More or less 2.4% of the kids that get cardiopulmonary bypass may require ECMO in the postoperative period. Also reports a survival of from the decannulation around the 70% mark, but there's a gap around 20% between the survival and the survival to decannulation to the survival of hospital discharge, which means that a lot of kids die before discharge. Around 60% of the kids overall get cannulated in a large meta-analysis of over 3,000 kids published recently, and they show there's a lot of variability between centers and in time, and probably related to the severity of illness and the underlying population. And more importantly, in a recent study from the ELSO database, we saw that around 20% of the kids that get decannulated die within the first 2 or 3 days from decannulation. That just means that having a successful decannulation doesn't mean that actually your patient is going to survive your hospital discharge. And this is a little bit what Tim talked about. And because we're talking about strategy, my question remains: what has to be true for the patient to come off ECMO? And I thought 3 are the important things. One is give time to the myocardium to recover. And we know that kids that get cannulated before the 48 hours mark have a reduced survival. The same with adults, which means you need to give time for the myocardium to rest. You need to have a reversible cause. If you don't address residual lesion, there's no chance that the child is ever going to come off, or he's going to linger off and he's going to get a second run and he's going to go back to theater. And as investigation during this period are fundamental. So echo at the bedside is very easy. Ideally, cardiac cath and CT angios are probably the things that we're doing most often at the moment, plus electrophysiological studies if the child has an arrhythmia, or post heart transplant, consider an early biopsy if there's early signs of rejection. As Tim described, 50% of the kids in some studies shows that were through cardiac cath they found some lesions that were not expected to find. So if you don't know why your patient is on ECMO, please investigate. Otherwise, there's no chance the child is going to come off. And at last, optimize and organ functions a little bit. Also, what Tim talked about: left heart decompression, support heart, lungs. Make sure that you have good end organ function and support on ECMO. Make sure your oxygen delivery to organ is fine, especially if you have a child with an open shunt and you need to increase your ECMO flows to maintain the systemic perfusion. Make sure your patient is not too fluid overloaded. If you think your patient is going to come off within 2 or 3 days, consider a little bit earlier ventilation, especially just to increase your tidal volumes, reduce the amount of atelectasis and reduce increase your surfactant production plus nutrition. So if all those three aspects are confirmed, and we work very hard to make sure that's gonna happen, the next step is to assess hemodynamic parameters at the bedside. So what you would like is to have a normal blood pressure per age, a normal heart rate, and a sinus rhythm, having a pulse pressure present, ideally more than 25% gap in terms of systolic, having normal end organ function, so low lactate and the normal SVO2. And depending on the underlying condition, have a NIAS above 60%, a normal CVP, and ideally normal PA pressure. And all this ideally on no Ionotropes, or at least on low amount of Ionotropes or vasoactive medication, having low ventilatory pressure and FiO2, ideally no fluid overload, and even more ideally in the absence of ECMO complication. All this has some limitation. First of all, is the fact if the patient has an LA vent, before you be able to assess all this, you have to take the vent out. Or if you have a child with a clipped or restricted systemic to pulmonary shunt, then the weaning and the assessment of the capability of the patient to separate from the circuit is going to be a little bit harder. And often the patient have to go back to theater and have it assessed there. Echo is still your best friend to assess readiness to come off. Usually flows are progressively reduced over probably 10-15 minutes. Weaning too fast of flows during the assessment changes very rapidly pre and after load, which means that your hemodynamic parameters will change a lot. We tend not to do it on Ionotropes. We just tolerate and watch a little bit rather than starting high dose Ionotropes during a weaning study. Some centers would. And of course, we continue to monitor signs of end organ dysfunction and SVO2, especially in the circuit. From the echo point of view, of course, you expect to maintain an ejection fraction at least above 35%, having an aortic VTI, which is a substitute of your stroke volume above 10. Some markers of tissue Doppler, especially the systolic velocities, and of course, no dilatation of the left ventricle or the right ventricle during the reduction of flows. How low do we go? Usually around 100 to 100 mils per minute. So the smaller kids sometimes still have a relative good amount of decompression related to the fact that you tend not to go too low with the flow for the risk of clot formation. And of course, kids with a Glenn and a Fontan circulation, where it's going to be much harder to estimate the level of effect of the ECMO circuit related to the decompression of the systemic vascular, of the pulmonary vascular resistance. It's going to be a little bit tricky to assess readiness. This is a study of a kid with single ventricle with open shunt, started with 170 mils of flow. Flows get slowly reduced. We look for presence of regurgitation or flow acceleration across the valves. The flows get further reduced in time. You let the heart preload. You try not to see any effect on the preload, so you don't want your heart to dilate in the meantime. In this case, we stopped the flow for a little bit, and the child maintained good contractility without any problems in terms of flow acceleration across the valve, with good hemodynamic parameter. And the child eventually came off the following day. All those predictors are not, they derive all from adult studies, especially from the French group, especially aortic VTI, left ventricular ejection fraction, and tissue Doppler changes while you're weaning. Your flows have been associated with successful weaning and decannulation of ECMO. A more recent study showed how left ventricular outflow tract integral on the wedge pressure ratio has showed a better prediction in terms of successful weaning. We never really use wedge pressure in children, so that they're all adapted to the pediatric world, but they've actually never really been proven efficacious. Another interesting adult study looked at the sublingual microcirculation. Those are 13 patients that adults that were cannulated for cardiogenic shock. they were weaned as per the normal protocol using 50% of flow reduction with changes in looking at the ejection fraction in VTI, and at the same time they looked at the amount of vessel density in the sublingual region, and they saw once the total vessel density goes up around the 14 millimeter per square meter, the patient was successfully weaned from ECMO. Also, this is not proven in children, so something that probably, hopefully, people will start researching and trying to find the same correlation in the pediatric world to help the weaning and the decannulation. As also Tim touched on, communication and planning is very important when it comes then to the next step, which is the decannulation phase. And the communication between team members, they have to deal with the preparation of the patient and the weaning process before the decannulation, where you would like the patient to be decannulated if it's either in ICU or in theater. Routinely, we tend to decannulate in ICU most of the patients, unless that they have to unwrap a shunt or reconstruct a shunt. So often they go back to theater for that. And another important thing is having a backup plan. So what's happened if you try to come off and you can't come off, or you come off and you need to go back on? All this needs to have involvement with the family and adequate communication from the beginning of the path, from the cannulation day up to the decannulation, and talking about alternative modality of support, destination therapy, or eventually palliation. Once you've done your weaning study, we tend not to come off the same day as we do the readiness study. We tend to do it the following morning. We prepare slowly overnight to make sure that all the hemodynamic parameters are in range. We start Lowdose Ionotropes. We start weaning the flow by a third. We start ventilating the patient. We use nitric if there's any query about pulmonary hypertension. And we slowly keep weaning the flows down, monitoring lactate and mixed venous and the NEARS. And then the following day, we tend to do another echo, make sure that there's no regurgitation, that the valves look competent, and the heart is not distended. And then we wean further by another third of the flows and down to around 200 mils per minute, aiming higher ACTs and APTs, and then probably we just come off from there. Levosimendan might help a little bit with weaning and decannulation. The adult study and the adult literature is not very uniform in association between the use of levosimendan with neither mortality at 30 days nor decannulation rate. We have a small retrospective study about 50 patients on levo and 90 in a control group in post cardiopulmonary bypass kit. In our experience, levo seems to help a little bit with decannulation post cardiotomy. Some center would consider it maybe if the first decannulation or the first weaning hasn't worked, at least as a support measure. How to decannulate and how to move forward. A lot of centers have a bridge within the circuit, so they tend to use the bridge and recirculate the ECMO circuit, flushing the cannulas regularly. Of course, that depends a little bit on your design of your circuit and your routine. We don't have a bridge, so we tend just to wean the flows and just come off. Of course, having a bridge has a potential risk of areas of low flow, clot formation, and embolic. Plus, you need to flush your cannulas. Another strategy, this is from a group in Brisbane. They tend to use a retrograde flow through your ECMO circuit. That's their experience with the 17 patient. They're not all post-cardiotomy. There's a mixed population. They retrograde the pump flow to a lower limit around 150, 200 mils per minute for a maximum of 4 hours. Of course, the potential harm is related to the fact that you could flush some clots from the venous side of the oxygenator back into the patient. Plus, you have potential problems with patient trying to come off and having high resistance and high afterload related to an old oxygenator and potentially high transmembrane pressure. Plus, if you have a systemic to pulmonary shunt, you'll have the heart needs to have a very high cardiac output to be able to compensate for the ECMO circuit, the shunt, and the systemic circulation of the child. So that seems quite a lot to ask for. Then it comes to the situation where you have a bit of a borderline myocardial function, and there's a marginal chance that the child is going to come off or not. We tend to just clamp the cannula, stop the circuit, disconnect the circuit, recirculate it, and have the surgeon there waiting for a little bit, starting some Ionotropes, and just titrating Ionotropes and making sure that the patient is actually ready to come off. And if we feel that the patient has good hemodynamics, we tend just then to remove the cannulas. That can last for 30 minutes, sometimes 60 minutes, depending a little bit on the clinical condition of the patient. A similar experience was recently described for post-cardiotomy kits too, where the team have left cannulas in for 24 hours after decannulation, keeping them flushed, and they showed they had a 69% survival rate to decannulation. Of course, the potential of leaving cannulas in is still relatively high in terms of still needing heparinization, the risk, of course, of infection and accidental dislodgement of the cannula itself. But they might be very useful in kits where the certainty of decannulation is not there. And we all know that the longer you stay on ECMO, the higher risk you have complication, which means that the higher the risk you're going to have a higher mortality. So tend to reassess in time. If you're running around the 2-3 weeks mark, then it's very wise to start thinking about if there's any other option in terms of destination therapy. And of course, if the family feels like the myocardium might not be recoverable and there's no other destination, would be one-way decannulation from there. And when we talk, of course, of decannulation and long-term support, it's very relative to, well, the institutional factors are very important, like as is the availability of organs. So it's really geographically dependent a little bit. Plus there are, of course, patient-specific factors like transplant candidacy and the chance that the child might recover or need a long-term transplant. So in conclusion, there's several factors that will influence the capability of your patient to be weaned off ECMO, and they're idiopathic, related to the underlying condition. Some myocardium are really badly injured at post-bypass and they never recover. So those are kids that where weaning is going to be really hard. Plus there are all the potential complication and the management before considering the weaning of ECMO that might influence the chance of coming off. Echo remains the gold standard at the moment to assess readiness for decannulation and for weaning. There's no really specific markers at the moment to be able to predict kids that will come off and not. And of course, successful decannulation doesn't mean that the patient is going to survive in the long run. Mostly because survival is influenced by a lot of other conditions, which is not just the coming of ECMO. It's mostly related to severity of illness. Pre-ECMO, the need for ECPR before going on, your indication, the quality of the surgery, intensive care therapy, and of course, ECMO support and potential complications on ECMO. Thank you.
Thank you very much, Roberto, also for a great talk. There's some very interesting questions coming in, and I can't wait to discuss them with you all. But before we do that, I want to switch and travel all the way to Boston in the United States, across a few time zones, and introduce Dr. Peta Alexander, who's a pediatric cardiologist, cardiac intensivist from Boston Children's Hospital, and who's been involved in the development of the ELSO guidelines. So she will discuss those guidelines with us now. Thank you very much, Peta. I'm very glad you're here. Take it away.
Thanks so much for the opportunity to join this really important webinar along with the European group. These are my disclosures that include being on the board of directors of the Extracorporeal Life Support Organisation, ELSO. These are the guidelines that I'm going to be referring to throughout the rest of this talk. And thankfully, you'll see that a lot of what we're talking about actually correlates quite nicely between what Dr. Jones and Dr. Chiletti have already spoken about. This was the authorship group, and if you're looking for them, the guidelines were published in the ASAO journal earlier this year. In order to to talk about an ECMO run, I think about it like this, and so just bear with me while I describe it a little bit to you. Obviously, the cardiac VA ECMO run sits in the middle of the screen in the blue box, but along the bottom of the screen, you'll see a time scale where there's events that occur before the ECMO run, events that occur during the ECMO run, and I've chosen 6 days for this ECMO run just because it was the median duration of ECMO support in our centre when I was starting this. And then obviously there's events that happen after the ECMO run that influence patient outcomes. The way you land on VA ECMO can make a big difference to your outcomes. So there's a smooth glide in a timely fashion, and then there's crashing onto VA ECMO, and I would usually consider this as an ECPR event. But certainly the events before ECMO cannulation set up your ECMO run for success or consequences, including more complications. As we addressed that for the ELSO cardiac guideline, we started with patient selection. Who should be an ECMO candidate in your centre? And this reflects very much what Dr. Jones and Dr. Chiletti have already discussed. In terms of overall indications, we agree that the periprocedural cardiac surgery patients are one of the larger indications for pediatric cardiac ECMO. And it can either be in the, we're talking about post-procedural at this particular talk, but you know that patients can go on before cardiac surgery or after cardiac surgery. And in the post-cardiac surgery process, it's either for failure to wean from cardiopulmonary bypass, for low cardiac output in the postoperative period, or for postoperative arrhythmia leading to a cardiogenic shock state. And the other cardiac indications that we included in the ELSO guideline are on the screen. Contraindications to pediatric cardiac ECMO are all relative, in my opinion. And so the relative contraindications to cardiac ECMO would be if there's been a prolonged state of cardiogenic shock, and that's really related to the end organ dysfunction that occurs with the lack of tissue oxygen delivery in that state. There's obviously a relative contraindication for prematurity or low birth weight infants, and extremes of prematurity are rarely approached in many centres, so less than 32 weeks gestation. Similarly, severe chromosomal abnormalities would usually be considered a relative contraindication, although if we're talking about post-cardiotomy ECMO, then these are patients who've already been selected to potentially benefit from a cardiac surgical procedure. And in our centre, certainly, these patients would be considered for early post-operative cardiac surgery, cardiac ECMO for recovery. Irreversible brain damage or intracranial hemorrhage should be relative contraindications, and uncontrollable hemorrhage would be another potential contraindication. Procedural factors such as the inability to be able to achieve vascular or central access for cannulation is unlikely in that early post-operative phase, and so that tends to not be a factor, as Dr. Jones said, for this population. There are some special considerations for patients in the peri and post-operative stage. Obviously, aortic regurgitation is a big problem for us with ECMO, and even moderate aortic regurgitation can become more impressive in the context of the LV afterload that comes with cardiac ECMO support. And we would obviously, if we're pushed to cannulate a patient with aortic regurgitation to ECMO, we would be looking at very early transition to cardiopulmonary bypass and decompression of the left side. In the preoperative period, interrupted aortic arch takes some real consideration, but that should ideally be resolved in the post-cardiotomy patient. But the stage palliation of single ventricular circulation does require careful attention in the early stages to management of the amount of pulmonary blood flow that's being maintained, particularly in the presence of an aortopulmonary shunt. And in the stage 2 and 3 palliation, the Glenn and Fontan circulations, the complex cannulation strategies that might be required to optimally manage venous drainage and support cardiac output have previously been described, actually. So I refer often to this cardiopulmonary resuscitation in infants and children with cardiac disease statement from the American Heart Association. This table gives a great description of the complex cannulation strategies that might be required for stage palliation of single ventricle disease. So back to the ELSO guideline then. If we've made it down as far as, yes, the patient's eligible for ECMO, the cannulation strategy needs to be identified. In the early postoperative stage, we would certainly look for central cannulation strategies almost exclusively, and other patients might be considered for peripheral cannulation. And within the guideline, we include basically a conglomerate of the co-authors and reviewers, assessment team and planning activities that occur around the time of patient cannulation to ECMO. So the assessment includes all of those patient candidacy factors that we've talked about already. The team includes that very deliberate assignment of cardiac surgical team, including the OR scrub nurses or assistants from within the ICU team, depending on the way you cannulate at your center, perfusion versus ECMO specialist versus nurse priming, ECMO attending, all has to be assigned to make sure that everybody knows where their role is and where they're positioned. We also include notification to the blood bank. The planning includes both the pre-cannulation planning, so what sort of access do we have? Do we have the right monitoring, the right airway, the resuscitation management that's going to be required during cannulation, as well as the actual surgical preparation for the patient. And post-cannulation includes those early assessments that are going to be required. Is the heart adequately decompressed? Do I need an echo, a catheter? Are we going back to the operating room early for that aortic regurgitation? As well as then how we're going to manage the early 2 days of resuscitation of the patient going on to ECMO. So this is all direct from the ELSO guideline. Back to my mud map, my mind map of an ECMO run. So we've basically got up to the point of the ECMO cannulation in this mind map of ECMO. But our goal for ECMO, as the other speakers have already identified, is basically recovery of the organ function that's precipitated the ECMO run without the new burden of injury, consequences, or complications of ECMO. And what we're aiming for is survival to ECMO decannulation and hospital discharge. What the family are aiming for is return to activities of daily living. Like, give me my child back so that they can go back to doing what they should be doing. And in order to achieve both of those things, we need to achieve recovery of organ function without additional burden of critical illness. And that's what we aimed for with the ELSO guideline, where we're talking about assessing the adequacy of support. So the patient's cannulated, you've already chosen your strategy. I agree with the previous speakers that the first thing that we do with cardiac ECMO is assess the need for LA decompression or left-sided decompression, depending on how the patient's cannulated. We'd then work out whether the circuit was functioning effectively, the cannula position, whether or not we're achieving target flows and what's restricting us with achieving those target flows. We'd look at pressure monitoring, and we'd manage any bleeding or clotting that's happening in that early postoperative stage, as well as attention to oxygen delivery to tissues. The way we think about that is basically with a couple of between 12 and 48 hours of post-resuscitation care, depending on the state that the patient went on to ECMO in. We'd also be looking at anticoagulation, hemostasis, and blood product transfusion. We'd be identifying and targeting hemodynamics of adequate oxygen delivery to tissues through good perfusion with normal filling pressures to protect the heart. And we'd be looking at sedation and neurological status with close monitoring for adverse events. Because the additional end organ outcomes or consequences that we're looking for are survival without new neurological injury and avoiding the hemocompatibility adverse events that contribute to so many of the other consequences of ECMO. And so in order to achieve the best hemodynamics, a lot of this is completely repeated from the previous speakers, but we would also look to early left heart decompression. And the ELSO guidelines that are copied into this image don't suggest one way of addressing left atrial decompression versus others, but rather use your institutional expertise to identify which option works for you, but do it early. To identify restoration of normal hemodynamics rapidly, it's worth being aware that the tissue oxygen delivery to the patient's end organs comes from the patient contribution of cardiac output, with systemic ventricle oxygen content, and the ECMO contribution of ECMO blood flow with ECMO oxygen content. And these figures are taken again from the guideline. I completely agree with everything that's been said about early identification of residual lesions. We would use a screening echocardiogram, but if the patient's not behaving the way we'd expect, then we would be moving to early cardiac catheterization. And in my center, it would still be cardiac catheterization. And not to disagree with anything that's already been said, but outside that early resuscitation phase, beyond the period of early post-cardiotomy myocardial stun, we would, where possible, look to maintain some cardiac ejection. As Dr. Chiletti said, somewhere around that 25%, a pulse pressure of 25% of the systolic blood pressure. And we would use low dose ionotropes if required for that. And my go-to would also be adrenaline or epinephrine, just at very low dose. So usually at that 0.02 to 0.05 mics per kilo per minute. 0.05 is a maximum. And I've included the table for indications of vasoactive infusions from the ELSO guideline. We use more vasodilators than inotropes on ECMO in our population. The patient management practice points from the guideline are equivalent to much of what's already been said, but we would address arrhythmias early to try and promote myocardial recovery, oxygen consumption, and cardiac ejection. We'd use vasoactive medications to manipulate SVR, so the vasodilators rather than the inodilators. And we'd complement VA ECMO flow and optimize tissue oxygen delivery. And that's according to the table that we've reviewed already. I would add inotropes later in the ECMO run at the point where you're beyond the myocardial stun to try and promote cardiac ejection and decompression, but recognizing they are not facilitating myocardial rest. And you have to recognize what you're getting from those at the same time as you recognize what you're losing. And we would give attention to oxygenating blood that's traversing the pulmonary vasculature, particularly in those patients with femoral VA ECMO, to avoid differential oxygenation and the lack of oxygenated blood delivery to the coronary arteries specifically. And so sticking with my mud map, the next phase of an ECMO run is obviously the weaning process and decannulation. And although I've put ECMO weaning as one specific time point at the end of an ECMO run, whenever that happens, we evaluate readiness for decannulation ideally every 24 to 48 hours after that early recovery of myocardial function post-myocardial stun. And we do it with the intention of not inducing additional myocardial injury. It's not helpful for anyone to go from full ECMO flows to clamped circuit to low cardiac output, no cardiac output, and then reperfusion injury of all of the organs that go back on ECMO. And in the ELSO guidelines, we specifically address determining the destination of each ECMO supported patient with reassessment every 24 to 48 hours. And the ultimate destination is either decannulation to recovery, concern for recovery or redirection of care, or conversion of modality, either for continued lung support, because as Dr. Jones said, the lungs can also contribute to comorbidity in patients who are supported for cardiac ECMO, or to a ventricular assist device, or ultimately bridge to transplant if the native heart's not expected to recover. And so these weaning steps are completely from the ELSO guidelines. And so the first step, as previously discussed, is to assess the heart rate, blood pressure, the pulse pressure, the overall blood pressure from an arterial line, the adequacy of tissue oxygen delivery as assessed by surrogates, including mixed venous sat, the lactate and NIRS, whichever of those are assessed in your individual programs. And we actually look at echocardiograms, not for all of the fantastic tissue Doppler and cardiac output assessments that have been studied in research studies, but we really just look for ejection fraction, systolic function, and some assessment of valvular function and PA pressure. So step one, assessing the cardiac function, gives us an answer every 24 to 48 hours of whether it looks like the cardiac function is A, improving, and B, adequate for potentially trialing off ECMO, or whether actually the cardiac function's inadequate at this stage and we need to continue on some sort of cardiac support. And the second step in our assessment of weaning strategy is to assess the pulmonary function. And so by assessing pulmonary function, we'd be looking at improved chest X-ray, improved compliance of the lungs on the ventilator, and then the adequacy of ventilation and oxygenation. So in the patient who's assessed as having adequate cardiac and adequate respiratory function, then obviously we move forward to the processes around determining timing and optimal location for decannulation. In those patients who have adequate cardiac function but inadequate respiratory function, then the team discussions could actually be around at what point we should be looking to consider conversion to VV ECMO versus what other optimization strategies do we have to improve the lungs. In those patients with inadequate cardiac function, it can still be a benefit to assess respiratory function, because in the case where there's adequate respiratory function, or indeed no respiratory compromise, then the timing should be considered about when we'd convert to VAD versus a bridge to transplant kind of scenario. And similarly, in those patients with inadequate cardiac function who continue to have inadequate respiratory function, we're stuck continuing VA ECMO, but we have to consider how we will optimize the patient for the next trial of weaning down the line. And that may simply be time if this is an early trial of weaning in that first 4 to 6 days post-cannulation to ECMO, but there are other circumstances where we've been on for a long time and the patient is not making progress. And I completely agree with everything that's been said about assessing for residual lesions, AV synchrony, and any other ways of optimizing cardiac support. And so this is my almost completed mind map of how I think about an ECMO run. And the only thing that I think requires some subtlety that's not expressed with the color coding that I've got on the screen is that obviously these things aren't just one single block from the start of an ECMO run to the end, but there are different time frames of ECMO, different aspects of support that need to be optimized and targeted during the run. And as the previous speakers have already mentioned, this was work that was done out of our unit by Katie Moynihan, and we do target early and iterative conversations during pediatric ECMO support. And while day 0, 1, and 2 are mostly similar, so let's just get you aware of where we're up to in terms of critical illness and likely progress from this point. By the end of day 2 or day 3, particularly post-cardiotomy, we've got a better idea of where we're headed with most of our patients. And so we can start to guide them through the alternate paths towards cardiorespiratory recovery. Complications occur at any stage during the ECMO run and may make this harder to persist with versus we've done everything we can and there's actually nothing more to be done. So we can start to move towards decannulation with end-of-life care. So again, reframing my local expectations of the ELSO cardiac guidelines, our cardiac ECMO management really does start with prevention's better than cure. Set up the ECMO run for success with excellent patient selection, the best timing of ECMO cannulation that you can achieve, and the best start to a run with the best venous drainage and arterial cannulation strategies. We are aggressive with left heart decompression to optimize recovery of ventricular function. We identify and manage residual lesions early. And we manage for native cardiac ejection during ECMO after that early myocardial stun with the most minimal support that we can offer. And again, that would usually be low dose adrenaline for us. We would trial weaning ECMO flows every 24 to 48 hours to see where we stand in terms of that potential for recovery. And we have iterative conversations with caregivers to build awareness, trust, and shared goals while we're doing it. And this is just some advertising for the next stage of consensus and collaboration that we're hoping to be talking about with you all in EuroELSO, including the contributors from EuroELSO that have included, but more on that at a different time. Thanks so much for your time today.
Thank you very much, Peta. Fantastic. I've received a few very interesting questions. I would like to spend the next 10-15 minutes to try and answer some of them, and maybe get a little discussion going amongst the team. Maybe we can stop sharing the screen and just have the panelists in view. I would like to start off with one question from Raphael, who's asking if you have a patient on VA ECMO, what do you use as criteria to go to the cath lab prior to weaning your patient? And I think I would like an answer from all three of you. Are there any specific criteria that you use? When do you decide to go to the cath lab? Tim, can I start with you because you were the first?
Okay, thank you. Yeah, good question. I mean, the criteria for me is any post-cardiac surgical patient who's on ECMO should have a catheter unless there's a reason not to. And so I would say that really you've got to find a very good reason not to investigate. It's often swayed a bit by the surgical opinion, surgical input, isn't it? As to how confident the surgeon feels with the repair or what imaging they may have done in the operating room. We fortunately work in a hybrid lab. It's a hybrid operating theatre. So if we go going on to ECMO in theatre, in the OR before we get down to ICU, we'll often just shoot the circulation. But if it hasn't been done, you've got to find a reason not to do it as opposed to a reason to do it, if you see what I mean. Timing wise, clearly if you're gone on to ECMO as a transition from bypass and you've got the capability, do it there and then. If you haven't and you've gone on an ECPR setting or in the ICU, it's often worth getting a period of stability of 24 hours, 48 hours, just for the patient, the team, the family, and then go to the catheter lab. The only other situation that would influence that for me would be if there is known to be a residual lesion or high index of residual lesion, you're going to need to resuscitate the patient because they've had an awful day in the operating room, resuscitate them, and then take them back, image them, correct the lesion, and often you can come off in that situation.
Fantastic. Roberto, is that something you agree with, or do you have a different approach?
I wish I have something to say against this approach, but I think we probably do exactly the same. I think echo would be still probably the first 24 hours, the baseline, unless the surgeon feels that something is left behind. So definitely with an image earlier, do a cath or CT, and then go back straight to theater. And as Tim said, most of the times they come off relatively very, very smoothly. Yeah, I don't really have much else to add, to be honest. I think it's very similar approach here.
Peta, same,
I'm going
different?
to be a little bit contrary. I'll be a little bit contrary without meaning to be, I think. Boston Children's is a really aggressive cardiac catheterization center. And 5 years ago, I would have said we go either direct from the OR to the cath lab or to the cath lab after cannulation within 12 hours. And that's certainly true if I need to decompress the left side of the heart. We don't muck around to get there. If there's any concern about the coronary arteries, either because of the procedure that was done or the mode of cannulation to VA ECMO, for example, ventricular fibrillation or VTAC, precipitating, then I think that there is real urgency to get to the cath lab because that's the sort of lesion that needs a fix if the heart is ever going to recover. I'm probably exaggerating a little bit. But actually, we have moved to early EEG management in the first 24 to 48 hours of our ECMO cannulations, particularly in neonates and infants receiving it. And going to the cath lab, even in our center that loves moving patients around a hospital on ECMO to the cath lab, it disrupts that post-resuscitation phase of stabilization and care. So I think that we're actually all in agreement, but I would nuance it just a little bit to say that we really are targeting resuscitation of patients and stabilization over a longer period of time than I would have earlier, unless it's a coronary artery injury that I'm concerned about, and then we'd be going earlier.
Okay, thank you. What about CT scans? Does anybody use CT scans prior to cath lab, or is it a different indication and you choose between either or? Anybody?
We used to be catheter. We've been developing our capability and capacity, and we've got some fantastic CT experts now who, I must admit, I was quite skeptical as to whether we could see what we needed to see. But on the last few runs, our investigation of choice has been CT scan, where we've gone to CT scan, and with the right timing of contrast and with the right route of contrast, we've had some spectacular images. And again, we can keep the chest closed. So obviously the problem often going to the cath lab is you end up putting a cannula, you're having to open the chest, put a cannula in the aorta to put the contrast in, you then get bleeding. But I've been really impressed by the quality of the CT images. And as long as you've got an experienced operator and interpreter, that now for me is often the first investigation of choice. Unless you're going to have to do some intervention. Clearly, if you've got to investigate and do a septostomy, then go straight to the cath lab. Don't waste the transport and instability going on a road trip around the hospital.
Yeah. If you've got an indication, if you're worried about something that might need an intervention, then you choose the intervention pathway. Probably that's what we like to do. Thank you very much. While I'm going to ask the next question to Tim, can I ask Dr. Peter Alexander in the meantime, people are asking for you to share the citation for the guideline. Maybe you can do that in the chat. Is that possible? And then the next question for Tim, and then I'm also interested in the other, in your thoughts. But Tim, you said that let me try and find the question again. Where is it? Yes. One of the goals is to maximize oxygenation of the myocardium, and I saw a very high post-oxy blood gas with a PO2 of 60 kilopascals. Don't you think that, or do you maybe think that too high a level of oxygen could be harmful to the myocardium? Not my question, of my colleague Arno from Nijmegen, but I think a very interesting point.
Yeah, good question. And I guess the question would be not just the myocardium, but the brain. And it is something that we are thinking more and more about. And actually, we are discussing it, and we have had a few approaches of bringing down that sort of superoxygenated blood going into the patient. In the immediate resuscitation, we do believe in sort of high flow, overflow for a neonate 130 mils per kilo with well oxygenated blood in the first 24 hours, 24, 48 hours. It goes on the lines of what Peter says to really try and resuscitate that baby. But you're right. I think the next step for us is to consider, the idea that we just put superoxygenated blood into the patient, and if the venous sats are above 70 or whatever, we were happy. I think we've got to begin to look at that, because every other avenue says that maybe superoxygenated blood isn't the best thing, particularly for the brain. More so of a concern, I think, than for the myocardium. I'll be interested to see what my two colleagues' thoughts are on that one.
So am I.
I missed the direct question, so ask us again.
Oh, sorry, yeah, I made you do something else. So the question is about hyperoxia. So you're maximizing oxygenation towards the myocardium by providing oxygen to the heart. Does too much oxygen damage your heart, or yeah, that's the question. Is it bad for you if you give too much?
You go ahead, Roberto.
Well, it definitely does, and it's been proven you can have a lot of reperfusion injury of myocardium. You have a lot of radicals, and you have a lot of injuries. I mean, that's what happens in post-bypass ischemia. Adult patient, they have a myocardial infarct. On note, we use nitric oxide, for example, on ECMO to reduce the reperfusion injury as a mitigator of that. And usually we just titrate RFiO2 to a mixed venous of 60 and a PiO2 in a normal range of 60 to 80, 100 sometimes.
Millimeters mercury, yeah.
Yeah, sorry,
yeah. No, just to be sure. Peta, any different thoughts?
No, very, very similar thoughts. I worry a lot about it, particularly in those patients who have single ventricle circulation who are deoxygenated at baseline, because I worry both for whatever injury we're giving them with hyperoxia in the acute phase, as well as over the period of 5 to 7 days that they are on ECMO, changing all of those compensatory mechanisms that they've got for shifting the oxygen dissociation curve that we simply can't measure. The 2,3-DPG and the microcirculation management. So I am very concerned about that in our population. I don't have a great way of addressing it yet, unfortunately. And as Dr. Jones showed very nicely, actually, nicer than I've seen before, I love that, with the serial blood gases, you can see when patients are recovering because they become more cyanotic, which is great news if you're trying to get them off ECMO, but it's not great news if you've been hyperoxygenating them for a period of time in the prodrome.
Yeah. Roberto, you said something about nitric oxides. So, and there's a question about nitric oxide and pulmonary hypertension. Who keeps nitric oxide on during a VA ECMO run in a child with pulmonary hypertension? What's your thought on that? Switch it off, turn it on, leave it on?
We wouldn't routinely leave nitric oxide. We just bypass the pulmonary circulation, so we probably wouldn't particularly bother.
And then maybe start it again at your weaning process the night before.
We usually start the night before, yes.
Yeah.
Once you start recruiting the lungs.
And I see Tim nodding as well. Do you agree? Do you stop?
Agree.
Yeah.
Absolutely
Yeah, agree.
And
Peta?
I also agree for everyone except those Glenn circulation patients that we've cannulated without a net cannulation strategy. So then I'd continue the nitric oxide if it was required.
Okay. I have a few questions about the cardiac stun and decompressing the left ventricle. Somebody is asking if you have a flat arterial waveline, what should be the appropriate approach? And we've talked about, or you guys have talked about the possibility of Ionotropes, and there's some disagreement. Somebody would use it a little bit sooner than others. There's the possibility of atrial septostomy or septectomy or left ventricle venting, excuse me. But what's your general approach if you see a flat arterial waveline? Is the question from the audience. From Tim, can I ask you?
Okay. Flat arterial waveline. Well, first of all, you've got to check your monitoring. And then once you've, we've got to go back to basics, haven't we? And this is always the problem. We're delivering high-tech ECMO and we forget the fact that the pressure bag's down on an arterial waveline. So we set up this whole cascade. Check your arterial waveline, get an echo, and look to see what's going on. And plus also, as I say, the gain settings and scale settings on the monitor can cause all sorts of trouble. So get an echo and look to see what's happening. Now, what am I looking for in that echo? I'm looking for two things. I'm looking for the decompression of the left side, and I'm looking for the opening and closing of the aortic valve. Now, even if I've got a flat line, if the left side of the heart's looking decompressed and comfortable, and the aortic valve's opening and closing, I'll sit with it. If I see that the aortic valve is not opening and closing, and the heart is distending, then I am really concerned. And I think for me, this is the true myocardial stun. So if I see that situation, then this is one of the few times where I would use my Ionotropes. And what I actually would do would be to drop my ECMO flow a bit to take down the afterload, give a bolus of adrenaline to try and get the heart contracting, and really, and if I've got pacing and I'm not pacing at that point, put a slightly faster rate on, get AV synchrony. These are all the things to try and get that heart emptying, because once it does begin emptying, the better. And if I've got a vent in, make sure the vent's working. If I haven't got a vent, then start immediately the process of deciding how you're going to vent that heart. And then the third situation is the left side of the heart's distending on your echo and the valve is opening and closing. Well, then, you know, you've got to check your vents working. If you haven't got a vent in, get a vent in. So those are really the ways I'd deal with those things.
Have any of you guys ever used intra-aortic balloon pump in your children? I guess the adults have much more toys than we do. I'm restricted to size. I've done it once. Do you have experience with a balloon pump on ECMO? What are your thoughts? Roberto,
I think I've used the last one probably over 10 years ago, and I don't think it was very successful. A lot of centers use impeller nowadays to decompress,
exactly.
especially the adult units. Some pediatric, speaking with Mark in Texas, he said sometimes they use impeller to decompress. We are still a bit old-fashioned. We just put pipes in.
Yeah, but we're also restricted by size, right? Yeah. Of course, we have larger children on ECMO, but in my experience, most of them are the smaller children.
And the problem is always when you have a closed chest, isn't it? When you have the open chest, and it's easy to decompress, isn't it? It's a myocarditis, so those kids that they need decompression, and you have a closed chest. Those are the ones that can be very tricky.
Yeah, and just to go back to the balloon pump point, of course, the elasticity of the aorta in the child pretty much negates any benefit from the balloon pump, because you lose the effect of the balloon pump because of the elasticity. So no, we haven't used that. As I said, like Roberto, the last time we used a balloon pump was off ECMO, and it was probably about 15 years ago in a child, and that was a much older child.
I think
it's interesting. I've seen it used a couple of times. Sorry, just the balloon pump. I'm sure that Roberto and I are talking about the same kid 10 years ago, and we've used it once or twice here. Once in an adult and once in a child, and both times it was in kids with Williams syndrome, and so they don't have the same elasticity, and so it kind of might make sense with the right pathophysiology. But the problem is that we're just not very good at it. I mean, we just haven't used it before. So I don't know if it was working right or wrong. I don't know if it was optimized. And so we had an adult physician come over, but it's not in our usual toolkit of ECMO support that I'm comfortable managing at the bedside. And so I don't know for sure that we used it in the best possible way. Similarly, the impeller, I agree, Texas Children's Hospital is probably leading the way with smaller kids on ECPella, so to speak.
Yeah. I want to finish off with one final question. Is there any way of training the ventricle when you're on ECMO? Let's say you have a late switch after a child with a transposition of the great arteries, deconditioned LV. We know that's going to take some longer time. We put the child on ECMO to rest, but is rest really the only thing that we can give, or is there anything that we can do to help them forward? Or do we just have to be patient and wait while providing the ideal circumstances? Anybody? Leave us some end in, Roberto?
We are believers here, but I'm not trying to convert, so I'm not going to preach about levo. I really am a believer. We tend to use it pretty early nowadays, within 48 hours from going on ECMO, especially if you think the kid's going to struggle to come off. Pacing always helps. You train a bit your myocardium without increasing the oxygen consumption. There might be some benefit rather than using ionotropes.
Because for ventilation, we have weaning strategies. We challenge them a little bit, and then we sort of train them. But for via ECMO, for this indication.
And of course, GOS have published, Great Ormond Street Hospital have published on this, on the use of ECMO for weaning for late presenting simple transposition. And I think that's a good indication. In the past, we'd banned and come back later, but I think certainly it's rare for us to see late presentation transposition these days. But if we do, I'd certainly favor going to the operating room. If we have problems post-operatively, then go on to ECMO and train on the pump. We have done it in a few cases of CCTGA, where we've done double switch and they've struggled sort of post-operatively, and we've ended up on ECMO. And then what we've done is gone through a sort of a training over a few days on ECMO by, when we see signs of recovery, reducing pump flow progressively and actually training the ventricle. And we know that the ventricle, if it is trainable, will train fairly quickly. And so I think it's a good indication. It's certainly something that we keep in our sort of toolbox.
And you mean then you wean more slowly, or do you go for a prolonged time, so like a sliding slope, or is it you wean them for a little bit and then go back to flow and then try it again later? Does it like this?
Progressive reduction. Yeah, progressive reduction. Get the heart working more. Get your vent out. You know, and let that heart do some work.
Fantastic. Listen, I want to thank you all.
Sorry, go ahead.
No, I wanted to thank you all, Peter. But and my last question was going to be, if you guys have any comments or questions amongst yourselves, because you've heard each other speak, or is there anything that you would like to ask each other? If so, this is the time. And otherwise, we're going to round it off, I think. Or last comments, final comments from you guys.
I have a question for everyone, because that really has been bothering me for a really long time, is someone starting the fact that we should run maybe single ventricle, not normal oxic on ECMO, and starting maybe leave them slightly normal oxic in the beginning, and then as soon, the first 24-48 hours they're stable, they have good end organ perfusion, maybe start weaning the FiO2 and get them more like on a kind of a bed system, isn't it? Just reducing the oxygenation and started training. I think no one will, or I think not a lot of people will restrict or clip shunts anymore. So I mean, chances are that everything is left open. So I'll be very curious to see if outcomes would change, because it's still the population that causes the biggest, at least in our institution, causes the biggest troubles.
I agree.
I agree with you that population needs a different strategy than we're currently using. I'm not sure. I'm not sure what the better strategy would be, but what you're suggesting is not irrational.
Yeah, and I think that this represents where, as I say, this represents where we're at, isn't it? 10 years ago, we were discussing whether we should, be using ECMO and when should we be using ECMO, and we've all gone through this sort of learning process of getting our patients on, and then the development of ECPR, and was that the right thing to do or not? And I think we're now into the next generation, aren't we, of application of ECMO, and we're seeing this, that the indications, rather than flogging the patient on high dose ionotropes, well, let's put them on ECMO because our morbidities and mortalities have improved. And I think now we've got to look at targeted therapy on ECMO, as opposed to one size fits all just because we wanted a survivor. It's now, well, look, we can do this, we're thinking about it, and I think this is the exciting part now, is tailoring the ECMO run to the patient.
Fantastic. I think that's a great final thought for this webinar. Again, thank you three for your great presentations, for your staying up very late and doing this during your busy days. I want to invite everybody to the EuroELSO meeting that's going to be in London in May 2022. We are still working on the program. It's probably going to be a hybrid, but we're not sure about that. But I'm sure the program is going to be very interesting. So please stay tuned for that. And also in the next couple of months leading up to the conference, we're going to do a few more pediatric ECMO webinars here from EuroELSO. So please stay tuned for that as well. And I hope to see you all on the other side of that screen again. Everybody have a great day. Thank you very much.
Thanks a lot. Bye.
Thank you, everyone. Bye.
Thank you.